Hello, my name's Dr. Amy Russell from the University of Leeds, and this is part 4 of a 4-module series of training on how to make reasonable adjustments to diabetes care for people with a learning disability. Part 4 focuses on coding, communication and change. Not deliberately the 3 C's, but it worked out that way and it's quite catchy. So I'm going to share my screen with you as always so that you can have a look at the slides as we go along. So the first thing is really going back to the start, coding. Now, I did quite a lot of research with clinicians working in diabetes care, in primary care, and I asked them, if you saw a patient who you felt had a learning disability, but there was nothing on their record to indicate that learning disability, what would you do? And the majority of them said, I'd probably just leave it. It's not my place to code. I might flag it or task somebody else, but probably not actually. And the general feeling was that even though they'd spotted it, it was really somebody else's job to validate registers, check coding was correct. And that is the way we work. You are quite right. That is how it's done. However, it's not being done. If you don't flag a lack of coding on somebody's record, if you don't highlight it and draw its attention to whoever feels able to code, then nobody else will. And we end up in this perpetual cycle of somebody not being coded correctly, not being flagged, and not receiving the services that they need. And so if you see somebody with a learning disability or you suspect they might have a learning disability, talk to them about it. I went out to the homes of nearly 200 people. They had been referred to me as having a learning disability, but they didn't necessarily have a code to put them on the register. I went and chatted to them. I explained my research was for people with a learning disability and asked them how they felt about being in research for people with learning disabilities. Quite a few said they didn't use the term disability about themselves because they saw that as a physical thing, but that they did have learning problems and maybe they'd been in receipt of learning disability services before. They'd been to special schools. Not one of them got deeply offended by the term. So it's worth having that conversation. Do it politely, but do it. Or if you don't feel you're able to do it, and you know, it's a conversation in itself, it takes time. If you've got a diabetes review to do, task the GP who's in charge of learning disability. If you don't have one, task the lead GP and ask them to have this conversation with this person, because if you don't do it, nobody will, and this person won't get the services they need, and those health inequalities that we talked about in the first module will continue to be perpetuated. I've worked with people in diabetes services outside primary care, and they've had patients arrive and there's been nothing on their records to indicate that person has a learning disability, and yet when they do arrive, they quite clearly do, and it's a surprise to them, and they've prepared no reasonable adjustments. So the next one is communication. In primary care, we're pretty good at communication. You know, we deal with such a variety of people. We've got used to adapting our message, but still, I do witness examples of technical language, fast speech, filling silences. So look at the person who's your patient. Speak clearly at a normal volume, but you understand the technical vocabulary. If sugar will do you need to use glucose? If blood test will do you need to use HbA1c? And I say that because even in the university, a lot of colleagues who are non-medical get confused at HbA1c. Try to say one thing in one sentence. Start a new sentence to say the next thing. I know that sounds forced the way I'm doing it, but actually pausing between each statement that contains one item really helps convey the message. Avoid negative statements. So saying we don't want to put on more weight. Do we want to put on more weight or not? Is more weight, so we would like you to lose some weight. Being overweight is bad for your health. We want to help you lose some weight, okay? Double negatives and things like that, or actually just negative statements, are really complicated to understand and they take longer. So simplify your language again. If you can do, give information in the order it's going to happen and walk somebody through a process. So the next time you come here, it'll be to see the healthcare assistant. She's going to take your blood pressure, and ask you a few questions. Then you're going to go home. The next time you come in, you'll see me. I'll have your blood test results by then, and we can talk about them. So pace it, lay it out as it's going to happen. Tell it like a story. Give people time to process the information. Sometimes silences feel patronizing or really awkward, but actually they're polite. They're the politest thing you can do to let somebody take in what you've just said. Check that they've understood. It's not a quiz. Don't make them feel bad, but just say, okay. So we've discussed a change there. Can you remember what we talked about that you're going to change at home? And if somebody says no, go, that's all right. Shall we try again? Maybe if I showed you a picture, it would help. Please bear in mind that people with a learning disability can be quite compliant sometimes. They might say yes to changes that you've come up with, which are not actually their own. And they might just say it to get you off their back or because they know that's what you want to hear. They may also be suggestible. Everybody is actually. They might change their response because of the communication used by you. And this could be verbal or non-verbal, especially if you say things like, you don't still have sugar in your tea, do you? I mean, it's a classic, but we can do that sometimes by accident because we're trying to be conversational. And they would tell you that, of course, they don't have sugar in their tea anymore, which would be a complete lie. But often they feel that getting the right answer for you is more important than actually the truth of what they're doing. They're interested in wanting you to feel like this has been successful. I know some people with a learning disability do absolutely love to be non-compliant, love to tell you no and to get lost, and then they're not going to do anything you say. And that's kind of part of who they are as well, and you've got to work with that. So I'm not saying that everybody's the same, but just think someone might be readily agreeing to a whole bunch of changes and really ask yourself, are they going to make them? Just one change and really take your time to explain it. So don't be scared to have these conversations about what they need in terms of communication. So this is a transcript of an interview that I did recently, and it is not an example of how to do this question. It's absolutely appalling with half-finished sentences and stuff, but you can see the woman does not get upset. So I say, so are you all right reading things, or do you? And she says, eh? And I said, can you read all right, or do you usually get someone else? Which is terrible anyway. I should have said, can you read all right? I shouldn't have given her an answer that she could do. But anyway, she says, I can read enough to get around. And I said, yeah. And I stopped and I let the silence go. And she says, but hard words, no. And I went, got you, okay. Validated her answer. And if you get a letter through the post, do you get some help finding out what it says? And she says, yeah, the support workers do that. So she's got a drawer with all her letters in. When she says she can read all right to get about or around, she can read the number on a bus. She can see the NHS logo on a letter. She can't read the contents of a letter. So if I'd taken her at face value, then I wouldn't have learned that. She certainly didn't mind this conversation. So phrases you might like to use. I'm sorry, I didn't quite catch that. Can you say that again? Is it to do with what you were telling me about testing your blood? Is it to do with your support worker? Shall we ask Bob, who's the carer who sat with you, because I'm not sure I'm understanding this one. And, you know, make a fool of yourself. Say, oh, I am not getting this. I am so sorry. Oh, dear. Can we ask Bob? He might help me. You know, the weakness is in you if you can't understand what the person's trying to convey. This is where the limitations of your communication and understanding skills come in, and you want to enlist somebody else. And that is a much more acceptable way than saying, I don't get what you're saying. I'm going to ask your support worker because I'm not getting you. So just think about the way you communicate. Sometimes when we're stressed and we've got a lot to get through with a person, it can get difficult to communicate properly. But that's why double appointments are also really important, because then you can have a bit more breathing space. So introductions really matter with this population. If they're coming into your service or seeing you for the first time or a long time, try not to do too much. Convey one thing per session, have one goal per session. And rapport building is important, and it can take several sessions, but it's worth doing. So don't feel that you're failing if you only get one message across, or the only thing you get is to understand where they eat and what they eat and their level of exercise. Actually, if you really feel you come away with that, that is pretty good, because that is so hard to get at. Ask open questions about what they like and dislike to get the conversation going. And don't take it at face value what they're telling you about their daily routine, because they may be picking one day that is quite unusual because it's the most interesting day. So for example, in our trial, we had to do serious adverse events. So I had to go out and ask people if anything serious happened to their health in the last year. And they would tell me about all sorts of things, relationship breakups, a hospitalization that happened 5 years ago. Anything really that they felt was interesting or I might like to hear about, but rarely did it actually come under the definition of what we wanted to know about for the trial. So it's really important to understand a person's life and to record what they're telling you, because your colleague might be the next person that sees them. So check their context. Where do they live and who do they live with? I've seen people with learning disabilities in family homes, but with elderly parents who maybe are also shielding, so can't come out. I've seen them in shared accommodation where they've got their own bedroom, but they all share a cooking space. Sometimes support workers cook, sometimes they cook. I've seen them in what would be more like a care home, where they have a bedroom, a communal space, and all the cooking is done for them. I've seen people living alone who only get no support, get in-house support, get 4 hours a day support. It's really different. So think about who does the cooking in your house, and it might change on a day-to-day basis. They might microwave a meal for lunchtime, but somebody comes in and cooks the evening meal. Or equally, somebody might put something in the microwave with 3 minutes programmed and they press the button and they're going to tell you they cook their own dinner. And who buys the food that you eat? Because again, that's a big one. Can you control what they consume if you don't know who's bringing the food into their house? So be clear which meals you're talking about. They might go out, or at least pre-COVID, go out and buy their lunch, but somebody else buys what's going to be breakfast or dinner. And I have a real bugbear about dinner because no one knows what meal that is or what time it's at. I think it's because I'm from the Midlands originally. But you get people talking about lunch and tea and dinner. So be quite clear what you want to know and why you want to know it, because these words are open to interpretation. And where do people go during the day? Again, this one was a bit more varied pre-COVID. People with a learning disability have really busy lives, a lot of them. They might work, volunteer, attend day centres or groups, have caring responsibilities, have social activities. I was trying to book appointments with people to do interviews with them and they were all over the place. And equally, somebody would tell me that every day they had a sandwich at home for lunch. But actually what they weren't mentioning was 3 days a week they were at the day centre where they would have a bacon sandwich and a can of Coke for lunch. But they were adamant that every day for lunch they were having a sandwich because that's what they had at home and that's what they thought and wanted to know. So it's these kind of routine changes that you need to establish. So you establish who's inputting into their diet and exercise. And then we need to think about planning their care going forwards. Here's an example of a health action plan off Get Checked Out Leeds. And you can use that to plan with them and have something for them to take away. Health action planning is pointless if they don't take away the message and the plan. Don't file them neatly at your end thinking that the person knows what they're supposed to be doing. They may well not. People recognise they need support with things. They often recognise they're struggling. They may be disillusioned because they've tried things before and it's not worked, but often they've tried to be more healthy or more exercise, and they haven't tried key goals that might be more achievable. So think about context when you suggest goals. Set it with the patient. The patient has to lead it. So as I said before, a walking goal is only feasible if the person feels safe and has mobility. If they can't get to somewhere that they feel safe to walk, they're not going to do it. Write the goal down so they can take it away. We never write things down in primary care. And it's a real problem for people who've got memory problems and also need to involve a team. If it comes from you and it's written down, it has a lot more clout. And check they understand what you're agreeing and tell them that you're going to ask them next time you see them. So making a referral to a health facilitation team. First of all, people with a learning disability will try mainstream services. That's the whole point. Everybody's supposed to get an equal opportunity to try mainstream services. You've got to make reasonable adjustments for them. It's your legal obligation. You need to give detail in their record about the reasonable adjustments you've made. First of all, if you ever get a complaint, you've got your evidence there. If these things ever get audited, your evidence is there. Secondly, you are making a record for the accessible information standard of what that person needs so that other people can use it. And also, if you do need further support, you've got evidence that you've tried your best to make your service accessible. So look at the inclusion tool at Get Checked Out, Leeds, and then think about contacting whoever it is that supports you managing people with a learning disability. So is it your health facilitation or health support team? Is it your community learning disability team? And you don't need to only contact them through a standard referral. You can get in touch and have a chat with them. This is what they do. They understand this patient group and they will support you, or at least they'll signpost you. So next steps, what can you do? What can you do now? Double appointments as standard. If somebody has a code for a learning disability on their record, give them a double appointment. Make that known to the person who books the appointments. Find out who you need to go to get further support and signposting. Who is your CCG lead for learning disabilities? Do you have a health facilitation team in your trust? Reach out to them. Say we're trying to make reasonable adjustments, but we could do with some support right now. Boom, they'd love it. They never get that. Right, get your learning disability lead. If you don't have one, get one. And your health facilitation team to review your LD register. Check your codes. Search for who's got a code of learning difficulties and get rid of that code and put a decent code on. Download our reasonable adjustments form off the diabetesuk.org/learning-disability webpage and use it. Work through it and check it off. And that's the web address for you. Also, look at Get Checked Out Leeds for their documents that support this process as well. And review your clinics. Has anybody got a routine appointment for diabetes coming up that needs a call? Talk to them about the fact that their doctors is still open for them, that coming in is up to them and what you're going to do to make it safe for them and what you expect them to do. Ask them if they can wear a mask. Explain to them that they may have to wait outside. Help them understand what the process is going to look like will alleviate loads of anxiety about how different things are now and how risky things are. Because changes in routine are quite terrifying for people who have very little control over them. So give them a call. This is a reasonable adjustment to help them make that appointment a success. If they come to you in such a stress and a mess because everything's different, you're not going to get much out of them, to be honest. And it's a question mark over whether it was worth getting them in. So do what you can to make it a positive experience for both of you. And a little star if you get it all done. So think about this. This is a whole process change. This isn't just one clinician doing their best. This is the way you recall your appointments. Who gets recalled at what intervals? Who do they see? Would it be a reasonable adjustment to let them see the same person? Would it be a reasonable adjustment to get them in every 6 months or 3 months? If they have a flag in their record, what are you going to do? Are you going to send an easy read invitation letter? Are you going to send easy read information to them? These things are possible as long as the patient is flagged properly and a new rule is implemented into all those who are part of that appointment process. Ask the awkward questions, have a conversation with them about whether they have a learning disability and code it properly. Introductions do matter, so build rapport with someone and take your time on it. A phone call can help that as well. Show them what you're talking about, don't tell them. Remember how powerful visual aids are, whereas words can confuse things. Get the basics right. Remember, we have met so many people who've had diabetes for years and still don't know why they should care about their blood sugar being high. Understand their lives, who supports them, who cooks for them, who shops for them, and you'll start to understand where you can make changes. Work with their supporters. Treat them as an amazing resource, but never talk to them over the person that you are supporting. Check and recheck understandings. Don't make it a quiz. If they don't understand, put the blame on yourself and say, I need to try that again. I've obviously not explained it properly. And agree goals between you that the person has selected and record them for that person to take away. Thank you for listening to this, as it has been a real whistle-stop tour through kind of learning disability training and diabetes specific training with a touch of pandemic specialist knowledge. I am ever so grateful that you took the time to come on this course and to read and listen to this. I hope you've got access to the materials that I've recommended, and I hope you get in touch with those teams in your own trusts to get signposted for further support. If you have any questions or queries, do get in touch. We always love to hear from people who've been part of the training, and I wish you the very best for making your reasonable adjustments.